So this is just an overview really of some information about JIA. The aim of the session is to give you a basic introduction to what JIA is, an opportunity at the end to ask questions, and I know there's only a few people here tonight, but it's always good to meet other people starting out on their journey with JIA and to share experiences. So just some very basic information that we often get asked around the time of diagnosis is, the first is how common is JIA? I think until you actually have a child affected by it, people think arthritis is very rare. It's actually not that rare in children. It affects 1 in 1,000 children in the UK, and in fact in most countries in the world it's about that number. That's a relatively common childhood condition, and it's as common as many other conditions that are better known. So it's much more common than people think. I think one of the things people find quite hard when their child's newly diagnosed, if you mention to a friend or a relative that your child's got arthritis, the response is often, oh, that's an old person's disease. Well, it's not. It's really quite common in children. What causes it? The honest answer is, despite many years of research and trying to find out, we don't actually know. It's lumped into this group of conditions that we call autoimmune, and I'll come back to that just a little bit later. Even the name can be a bit intimidating when you first hear it, Juvenile Idiopathic Arthritis. It's quite a long name, which is why we tend just to call it JIA. What does it mean? Well, it very much is what it says on the tin. So juvenile means it starts under 16 years. So if your child is 15 years and 11 months and gets arthritis, they'll be told it's JIA. If they're 16 and a half, they'll probably get a different label. So it's not an ideal term, but it's the best we have, and it's the best that we can go with at the moment. So juvenile just means it starts under 16. Idiopathic is a medical term for basically saying we have no idea what causes it. And arthritis means inflammation of the lining of the joints, and that's really what we're focused on and trying to improve with our treatment. So what do I mean by the lining of the joints? I think you may know, but just as a reminder, the joints are the bit where bones come together, and they're designed to allow movement in your limbs. So if we take this as perhaps an elbow joint, so this is the bone at the top of your arm, this is a bone in your forearm, and in between there's a space, because otherwise your arm wouldn't bend. So you need a space to allow your arm to bend. That space is surrounded by what we call synovial tissue, or this synovial membrane, and it lines the whole of this joining up space. And if it gets irritated and inflamed, then that's what we call arthritis. In between some of the joint lining, there's fluid, and there's always a little bit of fluid, but in inflammation that gets more. So what we're interested in as arthritis is this joint lining space. So it's not the bones, they're at either side, but it's the space in between and the lining of the joint. And when we talk about inflammation, again, you hear that all the time, and it's quite difficult to explain what that actually is. But inflammation is what happens when the body's immune system tries to fight off things that might be harmful, for example, infections. It's a very complicated process, which results in the proteins that control inflammation in the body getting out of balance. And those proteins are what we call cytokines. And you may hear people talk about some of the newer medicines blocking cytokines. They're part of the system of inflammation. And things like Amgevita block TNF, which is one of these inflammation proteins. And the problems arise if this whole complicated system gets out of balance. So, and what happens then is that the body's immune system fights against its own cells by mistake, and that's what we call autoimmune. So the immune system and inflammation are normally useful things, but if the checks and balances go wrong, then they cause problems. And just to show you a little bit more what inflammation is, this is obviously not the inside of a joint, this is someone's hand. but you can, if you try and imagine this going on inside a joint. So inflammation, when something's inflamed, it'll be red, it'll be warm, it'll be swollen, it'll be painful, and what we call loss of function. In other words, it's difficult to use. So you can see all that in this hand where there's an infection under the skin, but just try and imagine that inside a joint. We don't see that from outside. You don't often see red, hot, swollen joints, but that's what's going on inside, and that's what we're trying to treat and control with our medication. So what you'll tend to see in a child is this sort of picture on the outside. So this is a child with an obviously swollen knee. You can't see the redness and the heat, but that's what's inside. And that's why it can be uncomfortable or difficult for the child to use. Now that's a very swollen knee. It's often much more subtle than that and maybe difficult to see, but that gives you some idea, I hope, of what's going on inside the joints. So how do we know that this is JIA? And that's not always easy, and especially in younger children. Now, the couple of people who've joined us tonight, you both have slightly older children. One's a teenager and one was 10, I think you said. And sometimes it's a bit easier in older children to understand what's going on because they're easier to examine. A lot of the children we see may be toddlers when their arthritis start, and that can be quite hard to work out what's going on. And arthritis varies a lot. So your child may have one joint involved and only one joint, or they may have several or many joints involved. They may be in pain, or they may have no pain at all. They may find it difficult to use the joint, or particularly in younger children, they seem to carry on using often very swollen joints without any difficulty. They may be generally unwell and miserable, or they may just be their normal selves. And as some of you know, you can get eye problems linked with JIA, and that may be one of the early problems that we pick up. Early diagnosis and starting treatment promptly gives us much better results overall, but we still find children being diagnosed having had arthritis for really quite a long time, and we hear very frustrated parents telling us how long it's taken to get someone to actually give them the correct diagnosis. And again, we often think that's true more in the little ones, but actually I think it's often just as much in the older children, that people just don't think of arthritis in children. And the diagnosis will only be made if someone recognises the problem and considers the possibility of arthritis. And that's the problem, someone has to think about it. And often the first person to think about it may be a GP. It may be someone at A&E, it may be an orthopaedic doctor, it may be a paediatrician, but you need someone to actually consider the possibility, and that's often the point at which there's a delay. Usually once someone has thought of it, you'll be referred on to the paediatric rheumatology teams quite quickly, and we hope there aren't too many delays in actually getting to the specialist team once someone has considered that is the problem. And we have over a number of years in Scotland developed a whole network of specialist clinics, so there should be a specialist clinic in every hospital to try and make it easier for everyone to access a specialist as soon as possible. I know we're not living in normal times at the moment and there are delays to people being seen, but everyone should have a fairly easy access to a specialist. But it's that first step of someone actually thinking about the possibility. And that's why organisations like SNAC trying to raise awareness of arthritis amongst the general population, GPs, is really important. The more people think about it, the quicker children will be diagnosed. This is just to show you where we have specialist clinics in Scotland. So I think every hospital, every health board area in Scotland has a specialist clinic. There are some smaller hospitals like Elgin, for instance, where we don't have a specialist clinic yet. But every area has its own clinic with someone with a particular expertise in paediatric rheumatology. So we're very fortunate in Scotland actually to have that access to specialists. So how do we diagnose JIA? I think the most important thing is often just listening to the story of what's been going on. And you may, I think as a parent, it can get a bit frustrated being asked to explain yet again what's been going on, ask the same questions again, but some of it is piecing together the story is the most important thing. And certainly for me, I think hearing the story of what's going on with your child is often the clue to the diagnosis. So we'll want to know, what have you noticed as parents? How long has it been going on? Is your child in pain? And if so, how often? Does it occur to any particular pattern? Is there any pattern to when they have difficulty with their joints or to when they're sore? And have you noticed any swelling of the joints? And in an older child, we'll ask the child as well as the parents. And then also examining your child, and before actually touching their joints, that often involves watching your child move, particularly in little ones, look at how they're using their arms and legs, and then going on to a more detailed examination of the joints. And often by the time you get to the end of this point, it's very clear that's what the problem is. I think in medicine these days, we get very focused on tests and expect that you need tests to make a diagnosis, but you may well get a diagnosis of JIA without any tests. Once you've listened to the story, had a good look at the child, it's often very clear that that's what the problem is. There are tests that can be helpful, but they're not always needed and they don't always help. We do sometimes do blood tests. We sometimes do x-rays to make sure that there isn't anything else going on around the joint that might explain their symptoms. And we can sometimes do scans. So either an ultrasound or an MRI scan can often show inflammation in the joint, but it often just shows what we know is there anyway. So you won't always get those tests. So that's how we make the diagnosis. And I think for parents, getting to that point can be a very confusing and frustrating period. And once you get the diagnosis of JIA, it can get even more confusing. You're often bombarded with lots of information. There's lots to take on board. There's lots of discussion about the diagnosis. There's lots of discussion about treatment. And please don't feel you have to absorb everything at once. It often takes many months actually to get your head around what's going on. And some of the discussions about where to go for treatment can be very difficult. And often things need to be discussed several times with your nurse or your pediatric rheumatologist, and time for you to think about it at home and think about it before you can come to the right decisions together about what's right for your child. So I think, you know, whether you've been diagnosed for 3 weeks or 3 or 4 months, you're still in that very early phase when it can all be quite confusing and difficult to get your head around. The sort of questions that we often get asked, and there aren't easy answers. I would love to have had one of these crystal balls for many years, but I don't. The sort of questions a lot of people ask, and you may have in your head as well, was, why has this happened to my child? Why has it happened now? Why has it happened when they're 10 rather than when they're 40? Will they grow out of it? How badly will they be affected? How much treatment will they need? What about side effects of treatment? Are all children with JIA the same? So we hear these questions over and over again, and they're not easy to answer. But don't ever feel you can't ask them over and over again to your healthcare team. They obviously know your child best and can help you through trying to understand some of these questions. Now, once you've got a diagnosis of GI, you'll hear us talk about different types of GI, and that can get confusing. And if, for instance, you come to a snack event and are comparing notes with other parents, you may find everyone has a slightly different name for their child's condition, and that gets confusing. These are all different types of GI. Don't worry about trying to note down anything, because I think the slides will be available on the website at some point, and actually there's lots of information on the SNAC website about the types of GI. The least common type is what we call systemic onset GI, which can make a child generally very unwell, and these children are often quite sick with fevers, rashes, as well as their sore joints. Oligoarticular is the most common type, and that's where you have 4 or fewer joints affected. So the majority of children that we see have this type of GI. So oligoarticular juvenile idiopathic arthritis, it's not very easy names to remember. So we tend to talk about oligo-GI and just shorten the whole thing. That can be what we call persistent, where it stays with only a few joints. Oligo means 4 or fewer joints. So if that's all your child ever has, it's what we call persistent. If they start with a few joints and then later on get lots of other joints, it's what we call extended oligoarticular. So those are terms you may hear, but don't worry about them if they don't apply to your child. Polyarticular just means lots of joints. And if your child has that diagnosis, they'll tend to be tested for what we call, the old-fashioned test was a rheumatoid factor test. A lot of labs now do what we call a CCP. And that is basically trying to determine whether they have what's more like an adult type rheumatoid arthritis. So if they have a positive blood test, it's still called polyarticular JIA, but we know it's more like the type of arthritis that adults get. There's GI that's linked with psoriasis, often either psoriasis in the child or psoriasis in the family. There's this terrible name called enthesitis-related GI, which is often boys, usually boys over the age of 9. And it's really the only, this and psoriatic GI are the only types where you get back involvement really, and even that's quite uncommon. And they follow a slightly different pattern. So as well as joints, they often get inflamed tendons. And the reason it's important is sometimes the treatments we suggest may be slightly different depending on the type of pattern that your child has. And then there's a very large group of children who we see they've got GI, but they don't fit nicely into any of these categories, and we just call it GI. And maybe we should just call it all GI and not make it so complicated. So those are the different subtypes. And as I say, we can chat more later, but if you want to read more about them, there's a lot of information on the SNAC website. So that's about the diagnosis. I think an awful lot of this discussion in the early days of GI are about treatment. Often your child can seem quite well, and one of the questions we often get asked, well, why are we bothering to treat it? It's not bothering them that much. Why are you making such a fuss about it? There's 2 reasons to treat GI. The first is short term, because some children aren't well and don't feel well. They maybe don't realise how miserable they feel until you make them better. But short term, what we're concerned about is your child should be well, they shouldn't have sore joints, and they should be able to join in all normal childhood activities. And that's really important. If your child should be normal and feel as normal as possible. And then equally important is the long term. We know, and we know because there are still many people around who had GI in the days before we had effective treatment. And we know that if we don't treat GI in children, we see young adults with very damaged joints. And we don't want your children to be like that. So we know that we can prevent a lot of damage to joints by getting that inflammation under control. So there's the 2 reasons to treat GI. There's the short term and the long term, and I think they're both equally important. So what are we trying to do with treatment? I tried to explain a little about what inflammation was earlier on, and what we're trying to do is get that under control. We can't cure GI. We can't give you a medicine and say, that's you cured, that's the end of it, it'll never come back. But what we can do is get it under control. And sometimes it will burn itself out and go away itself. Sometimes it won't, and we need to keep it under control with medication. And the plan of treatment for your child, obviously there are things we do that are very similar, but it is very much an individualized treatment plan for your child. And there's lots of discussion going on in clinics about how much treatment does your child need, what treatment should be on at what stage. And we try and use the right level of treatment for each individual child. And medicines are really important. You can't treat GI properly without using medicines in one form or another, but they're only part of a child's treatment, and there's a whole team approach to helping children with GI that we feel is really important. And this is the sort of team that I think you will come across if you're dealing with a child with GI, and that can be a bit overwhelming as well as a parent, meeting lots of different people who all have different things to suggest. And different hospitals will have slightly different teams, but the kind of things we think about are important in managing GI. So the most important thing actually is the parents. You're the most important person in managing your child's arthritis, and therefore knowing, trying to understand what's going on, learning a bit is really important, but don't ever feel the responsibility is all yours. your team are there to share it and to help, but it's very much a joined up approach between the family and the medical team. I think the most important people in treating JI are probably the nurses that you come across. They provide a huge amount of information, support, help with managing treatment, and we're really lucky to have an amazing team of paediatric rheumatology nurses in our clinics, and you'll probably get to know them better than anyone else in their team. Doctors obviously are part of the team, and they may be either the hospital doctors or your GP. Both are important in helping. Not all children with JI will need or will see a physiotherapist, but many of you will see a physio at some point, and sometimes there'll be a physio in clinic. We'll talk a little bit about what some of these people do just later on. An occupational therapist may have a role in helping your child. Every child with JI will see an ophthalmologist to get their eyes checked to see whether there's any inflammation in their eyes. Pharmacists help with a lot of the complicated medicines that we use nowadays. Radiologists manage x-rays and scans. School is a really important place for children, and liaising with school, helping them understand what's going on is really important, and that's all become incredibly complicated at the moment, of course, with schools being closed and a lot of discussion of what will happen with back to school. But school's an important place for children, so helping them understand what's going on is also important. Many children with JI benefit from some form of psychological support. I think it's really difficult going from being a healthy child to within a few months having to put up with lots of injections that can make you feel rubbish or are stingy or hard to manage, and both children and families often benefit from support, from some form of psychological support. And then support for the whole family, and that's where we're very lucky to have SNAC, who are here to help and support you and help people support each other. So just a little bit about medicines. As soon as you mention medicine in a clinic, the immediate question we tend to get from parents is, well, do these medicines have side effects? There are no such thing as medicines that have no side effects. You know, every medicine that's ever been invented has potential side effects, but we actually see very few serious side effects with the medicines that we use in rheumatology. And again, it's always a question of weighing up the balance of the risks of treatment against the risks of not treating. I started paediatric rheumatology in the days before we had any of the treatments that we have now, and I can tell you the risks of untreated arthritis and what that does to children is huge. We used to have clinics full of children in wheelchairs. We now have clinics full of children who hate their treatments but are usually quite well. And so that's the juggling act we have to do, trying to get your children as well as possible, keep them well, protect their joints for the future, and cause as few problems as possible. But I think there's no doubt there's much higher risk of damage from untreated arthritis than from medication. So the sort of medicines that we use, and this is just a very brief summary because it's very individual for different children. Painkillers can help, obviously, if your child's sore, but they don't make the arthritis go away. They can just make it feel better. And we tend to think of anti-inflammatories in that same group. So things like ibuprofen will often help damp down the symptoms, but it's very temporary and they'll just come back again. So these can help, but they're not really treating the underlying problem. Steroid medicines are very powerful anti-inflammatories that work quickly. And so when your child first presents, if they've got a lot of swollen joints, we'll often use steroids to start the process of things settling down and help your child feel better. They're very effective short-term treatments, but they come with a lot of side effects if used long-term, so we tend just to use them in short bursts whenever we need to. They can be given as tablets. They can be given as infusions into a vein. What we tend to do mostly in children with arthritis is inject them straight into the joint, as we're doing here. So, because what you're doing is putting the medicine where the problem is and reducing the amount that goes into their system. So you get the benefits without the side effects. Now, obviously in 2-year-olds, this is quite a tricky thing to do, and it means a general anaesthetic. So that's the downside in younger children. In older children, we can often do it either with just numbing the skin or with some local local support such as Entonox, which is what we use for a lot of older children having joint injections. But we use a lot of injections into the joint. They're very quickly effective and cause very few problems. So you will find that's an often suggested treatment. Again, it's slightly more tricky at the moment because some teams have struggled with access to theatres, for instance, during the acute COVID situation. But most children with JIA, if it doesn't settle just with injections, will go on to more ongoing medication. Now, not all. Some will have injections and not need any more than that. But most children will go on to what we call disease-modifying anti-rheumatic drugs that actually control the disease in the long term. These have been around for a long time. So we started using methotrexate in the early 1990s. So it's been around for a long time in rheumatology, and we know it's safe. Everyone worries about long-term side effects of medicines. We have had very little evidence to suggest that these drugs cause any long-term problems, and the methotrexate particularly is well tried and tested. I know a lot of children don't like it, but it's safe and it's got the best record in terms of effective control of disease of all the medications that we use. And that's why we use it. People say, why do you give our children this horrible drug that can make them feel yucky? It's because it works and because it's safe. It's often started on its own and then often combined with one of the newer, what we call biologic DMARDs, which are the newer drugs that are designed to target some of these cytokines that get out of control in inflammation. And there's a whole lot of them. Amgevita has probably been mentioned tonight, and that's probably the most commonly used one now as a first choice, but there's a whole lot of them. They all are given by injection, and that's a real downside for children. They don't come as tablets or medicines. And probably alongside that, there's a lot of other things that can be done to help with your child with arthritis. And I think as parents, a lot of the general health things are really important. A good healthy diet. A lot of people ask, is there a particular diet that will make their arthritis better? And there's lots of people on the internet who will sell you dietary cures for arthritis. I have to say, I've never seen anyone come up with any evidence that any of them work. And it's really important in children that your child has a full range of nutrition to help to allow them to grow and develop normally. Children don't cope well with restricted diets. If you want to try different diets, then always check with your healthcare team. But the biggest problem we have in this country, of course, is overweight children, and that doesn't do your joints any good. So just a normal healthy diet encourages healthy bones and healthy growth, and that's good for your joints. Exercise. In the dim and distant past, people used to be told to rest if they had sore joints. We know now that's the worst thing you can do, that joints benefit from being exercised even if they are inflamed. And children definitely benefit from being exercised. So keep your children healthy and active is one of the really important things. And the other thing that's often not mentioned but is really important is healthy teeth, particularly if you go on to things like some of the biologic medicines. If you have infected teeth, you're much more likely to get abscesses and things with it. So good dental hygiene is really important, and regular checkups. And again, we're not very good in Scotland at having children with healthy teeth, so that's a really important part of just general care. Physiotherapy is useful for many children. Not all of them need it. Physiotherapists will help to treat stiff joints. They'll help improve muscle strength. They can often help with pain and stiffness. They're often particularly helpful if your child struggles with back pain, which often isn't arthritis, it's often for other reasons. And physios are very good at treating backs. And they can often help your child return to normal activities, which is what we're aiming for, that children should be normal and doing all the things they want to do. An occupational therapist, not everyone again will see an occupational therapist, but if you have one in your team, they will help with things that can affect function. So, they can often help if your child has arthritis in their wrist or fingers, they can help with handwriting. They often help sort out problems at school. Some of the nurses will overlap with these sort of help and support, and they can often help with sleep. So they do lots of things to help improve your child's function. I mentioned before psychological and family support. I think that's really important. If you're struggling with arthritis, ask for help. And that can be from the professional team or from organisations like SNAC. Don't struggle alone. We don't have an easy fix, but at least sharing the burden can help. And we do try and take a team approach to management with everyone working together. And just lastly, this isn't something that goes away overnight. It's what we call a chronic condition, and helping your child and helping you as parents, there's a bit of adjusting to it and learning to live with it. And part of that is trying to learn a bit more about the condition, understanding the condition and its treatment. In a more normal environment, we would often have, for instance, the CREEF weekends are great for bringing children together and allowing time to talk to them about their arthritis, doing a bit of education. Obviously, we haven't been able to do that this year, but we'll get the opportunity to do that again, and helping children understand their condition and the treatment is really important. I think often when you're started on a treatment, one of the most frustrating things is you start treatment and a month later you think, well, I'm not any better. And that's really frustrating. I'm giving my child these injections or this medicine and it hasn't worked. The treatments we use take time to work, and I'm sure your healthcare team will tell you that, but it's sometimes hard to take it in. And every time your treatments change, you need to allow about 3 or 4 months to see if it's going to work. And that's the hardest bit, I think. You try a treatment, 3 months later, someone says, well, it's not working very well, we'll up it a little bit, and then you have to wait another 3 months to see if it works. And I think particularly for older children who are not enjoying their treatment, that can be really hard. What I would say is at the end of the day, we nearly always find something that works, but it may take a bit of trial and error to get there. And I think the other thing just to keep reinforcing with your children and as parents is most children with JIA do very well. Most children we see are leading normal lives, often participating in high-level sport, doing absolutely everything they want to do career-wise. The only career pathway that is blocked really to young people with arthritis is joining the armed forces. But that's just because they have a rule. But other than that, they can and should be encouraged to consider anything that they want to do. There's nothing that they should do any differently from anybody else. So encourage your child to be normal, but don't be afraid to ask for help and support. And I've touched on this. I think the most important thing is that everyone's in this together. So parents, carers, young people, professionals, we all want to work together. And that's where things like SNAC come in. So SNAC is the organisation for families. SPARN is the parallel organisation for professionals in Scotland, and we work very closely together. Your local team will be the team that knows you and your child best and can usually give you the best advice and the first advice. But again, around Scotland, we all compare notes. If someone's struggling with a child who's not doing well, we'll usually have discussions about it around, share with colleagues, so you will benefit from everybody's advice. And the other thing, I'm not going to talk about research tonight, that's a whole different topic, but there's lots we need to learn about arthritis, and anything you can do to support arthritis can only benefit children of the future. You will almost certainly at some stage, you may well be asked about whether you're interested in being part of a study. I think at the moment, everything again is focused on COVID, but that will pass and there'll be other studies going on. And I would encourage you, if you do get the opportunity to be part of studies, then to think about it carefully, because we're learning all the time. We don't have all the answers, but we have learned an awful lot in the last 20, 25 years. And I think the future is bright. We're learning, we're understanding more, and we'll get there. But we'll get there together. And I think that's all I'm going to say.